Hello, everyone, and welcome. Today, we're going to discuss our week one lecture, and I'll be sharing my PowerPoint with you, and we will be discussing ICD 10 coding. My name is Cynthia Bennett, and I will be your facilitator for this session. So, first, I'm going to share my screen with you. Okay, you guys should be seeing my screen now, and I'll start the presentation. So just a few tips. You want to make sure that you manage your time in the course. The course goes very quickly, so you can do this by scheduling a few times throughout the week to complete your assignments. Also, read your weekly announcements and emails. Sometimes we're sending you tips and information there, so it's important that you review those on a regular basis. So I'll be sharing some coding websites with you. So you want to check your announcements. So one of the websites I like to use for diagnosis coding is icd10data.com, and I'll have those links inside of the announcements. So we'll be reviewing chapter 1, which consists of coding career opportunities, joining a professional association, obtaining a coding credential, networking with other coding professionals, opportunities to advance, a coding overview, and then also health data collection. So the first thing is, how do you believe clinical documentation improvement and the physician inquiry process and the use of computer-assisted coding and encoder software impacts a coding career? So it definitely will impact your coding career. The documentation is basically used as a tool to communicate with others. So the physician will document the patient's visit. We can use it for computer assisted coding. Also, we can use an encoder software, which what that basically does is helps you to assign your different codes from your ICD-10 to your CPT, HCPCS, and also ICD-10 PCS. So as a coder, you're going to be required to review the documentation and then assign the codes based off of that documentation. So you'll be using the different coding systems where, again, you'll be communicating with different insurance companies and governmental agencies. So again, the coding systems that you'll be using is the CPT, HCPCS, ICD-10, and ICD-10 PCS. So it depends on where you're working will determine if you'll be using the PCS or not. But everybody uses the CPT, HCPCS, and ICD-10, CM. So as far as your training, this is going to be a college-based training that you can receive, or you can do a non-credited program. But ours in particular is going to be a college-based program. And this is where you're going to have courses in healthcare science and then also coding and reimbursement. So as far as your internship, it normally will occur at a healthcare facility. Um, Most of us are doing it online, so it'll be through a healthcare facility, but it could be in person or online. So some of the coding credentials that you can kind of determine which one you would like to do. There's a few. So here is the ones that are offered through AHIMA, which is the American Health Information Management Association. They offer the CCA, which is the coding associate, the CCS, which is the coding specialist, and then they also offer the CCSP, which is the coding specialist physician based. So I recommend these certifications under AHIMA if you're going to be working for a hospital organization, or you're going to be working with hospital-based claims. So then you also have the AAPC, which this some of the certifications that they actually provide is the CPC, which is the Certified Professional Coder, the CIC, Certified Inpatient Coder, COC, which is the Certified Outpatient Coder, and then they also have some other specialty coding credentials that you can get in other areas, such as um, compliance, auditing. So you also can get a certification in the different specialties, such as cardiology. So they offer a wide range of certifications. So again, the AAPC is the American Academy of Professional Coders. So some of the employment opportunities. So where could you possibly work? So you could work in any healthcare setting. So this could be a hospital, a physician office, an insurance company. So there are many different types of locations that you can work. You can work for a billing and coding company where that's all they do, because some offices will outsource some of the different types of coding. So other professions that are related to coding, this would include your health insurance specialist, claims examiner, and medical assistant. So these are closely related. They work together. So you may encounter some of these other professionals while you're actually working in coding. So here are some of the other professional associations that you can join. So as a coder, the most common one is the AAPC or AHIMA. But if you just want to be a health insurance specialist, you can actually join some of these other organizations and possibly get some of these other certifications. So another one is the Alliance of Claims Assistance Professional. You can also get the Medical Association of Billers. And then for your medical assistant, American Association of Medical Assistants, or the American Medical Technologists. So these are just some different associations that you can possibly think about joining. You can join one, you can join two, you can join all of them if you want to, because you can join as many associations as you want to. And then they all will offer different types of certifications. So for AHIMA, you're going to go to www.ahima.org. For AAPC, you'll go to aapc.com. And then if you want to learn more about Medicare Part B, this is a great forum that you can join, a community where we'll give you more information about coding, billing, reimbursement, all these type of things. You'll find more information about if you join one of these websites. And all of them are pretty good. So you can join one or you can join all of them. It's just up to you and your preference and what you are interested in doing and which organization you prefer. So the coding systems and coding processes. So I mentioned before, the systems will be the ICD-10 CM. This is for your diagnosis. ICD-10 PCS. This is for your procedures. CPT is also for procedures, but these are for your professional procedures. For example, your physicians. HCPCS coding level 2, and this is where you're going to find like different supplies, medications, transportation. All of those will fall underneath the HCPCS. So in your HIPAA code sets, you'll have your CPT, which is your large set, and then you'll have a small set, which will also be places like your types of healthcare settings. These are some different coding references that you can use. So once you start coding, you can actually join the AHA coding clinic. where they'll be reviewing different types of ICD-10 coding. You have the AHA coding clinic for HCPCS and CPT as well. So you have some different coding resources that you can use as you are in your coding career. And you can also use them now as well if you would like. So these are some of the things that we want to avoid when we're actually coding. So we want to avoid fraud and abuse. So one term that you'll hear is something called unbundling. And this is when you're reporting multiple codes to increase your reimbursement for a single combination code. So what that means is basically, if it is a code out there that will cover 2 procedures, which will be 1 code, but you decide to bill it as 2 procedures when there's actually a combination code already available, this is what we will call unbundling. So for example, a patient can come and get a some type of radiology study, either with contrast or without contrast, or the doctor could order with and without, where there is a code for with contrast, there's a code for without contrast, and then there's a code for with and without. So unbundling would be if the patient got the with and without, if you build the 2 separate codes versus billing that code for the with and without as the combination code. So upcoding is when you're reporting for codes that are not supported by the documentation. So a good example of this is, for example, in your office visits. If the documentation supports a level 2 office visit, but you code and submit a level 3 office visit, this is what we call upcoding, because the documentation only supports a level 2 code, but you coded it as a level 3. So this is what we call upcoding. So overcoding is when you're reporting for codes for signs and symptoms in addition to an established diagnosis code. So for example, if the patient has pneumonia and then the patient in the chart is listed as the patient is having coughing and chest pain. Well, coughing and chest pain is a part of pneumonia. So therefore, we're not going to code the coughing and the chest pain because it's already a part of the pneumonia. So we want to make sure that we don't do things like that. So another thing you want to avoid is what we call jamming. And this is routinely assigning an unspecified code instead of reviewing the coding menu to see the more appropriate code. So we want to make sure we stay away from that. And then also down coding, because some people think that if I down code, this is actually a good thing because I'm not over coding or I'm not up coding. So you want to make sure you stay away from that. So down coding is routinely assigning lower level CPT codes for the convenience instead of reviewing the documentation and the coding manual to determine the proper code. So sometimes people would just down code and they figure, okay, if it's below what it really should be, I'm okay. No, we shouldn't be doing that either. We should be assigning codes based off of the documentation that is provided. So the medical coding process. So we always want to adhere to the code of ethics. We want to follow the steps to accurately assign our codes. We want to ensure coding quality. So going back, reviewing your coding, making sure that everything matches, the coding matches the documentation. We want to avoid assumption coding. We never assume anything. We're only going to code what's in that documentation. So if someone comes behind us, they can see why we coded that. Also comply with clinical documentation improvement and coding compliance programs. So most offices will have a coding and compliance program, and you need to comply with the recommendations of that program. So professional coding versus institutional coding. So there are some differences. And so this can actually help you determine which type of coding you're interested in doing. So with professional coding, it captures complexity and intensity of the procedure performed and services provided during an outpatient or a physician office encounter. So facility-based, or what we call institutional coding, captures the intensity of services used to provide inpatient care and the severity of the illness to classify how sick the inpatients are. So it's slightly different. So this is just something that you just have to think about. Then you also have multi-hospital systems that provide physician office services and have implementing a single path coding, which combines physician or professional along with your institutional coding to improve productivity and to ensure the submission of clean claims, leading to the improved reimbursement. So those are just some of the differences in between the professional and institutional coding. So the physician query process. This is used to contact the physician to request clarification about documentation for code assignment when questions about the documentation arises. So if you have a question based off of the documentation about what the doctor actually meant when they were documenting, you'll actually query the physician to get clarification. Now, sometimes maybe we just didn't understand what the doctor actually meant. Maybe the doctor may need to add some additional information to clarify some things, but never make any assumptions. We only can code what is there, but we can ask the doctor for clarification. So the EHR allows development of an automated physician query process, which is utilized by your manager or case managers or any type of clinical documentation improvement specialists or coders to obtain clarification on a patient record. So in the EHR, a lot of times you can send a doctor a message and ask for clarification on that medical record. So that is a fairly easy process. And in some organizations, they will query the doctor and they may use an email. So it just depends on how the organization is set up and how they want you to query the physician. But it's still asking questions about the documentation. It's just a matter of what method is going to be used to submit that information to the physician. So integrating the automated physician query process with the EHR allows the physician to more easily receive and reply to queries, which result in better and timely responses from physicians. And this is true because we can actually link that documentation with our question and a message to the doctor. So the doctor can just click on our message. They'll have access to the EHR, the medical record, and it's all within the same system. So we're not using an outside, for example, email system to contact the doctor. Now, some offices may have it where you'll contact the nurse for clarification. So it just depends on the office. But if at all possible, you should go directly to the physician. But I have seen situations where it may go through a nurse first, and then the actual doctor. Or maybe the nurse can just, pass the information on, get the information from the doctor, and then you just move forward with the information that's resubmitted back to you. So clinical documentation improvement. This helps to ensure that accurate and thorough patient record documentation, and it helps to identify any discrepancies between the provider documentation and the codes that are assigned. So coders who have questions about documented diagnoses, procedures, and services can use the physician query process to request clarification about the documentation that impacts that code assignment. So again, if you're not sure about something, maybe ask your supervisor first. Maybe they can give you clarification. That may be a way as well. It just depends on how the office is actually set up, how they want you to do that query process. For a physician query process, coders may coordinate with utilization management employees who routinely meet with providers about the medical necessity of the continued patient stay. So if you have someone that's routinely already meeting with the doctor, maybe you can work through a process with that person, and then they can actually work with the doctor to get the answers to the questions that you possibly have. So that is another good way of going about it. I've seen it done that way as well. So coding compliance. So every office should have a coding compliance program. So even if it is a small office, someone should be over the coding compliance. Now, some offices, if it's small, they may opt to outsource this and use someone from the outside to keep up with their compliance. So what the program does is it ensures the assignment of codes to diagnoses and procedures and services followed by the guidelines established by CMS, so that they actually take the guidelines from CMS and then apply those to the coding that they're actually reviewing. Also, healthcare organizations can write policies, guiding principles that indicate what to do, and the procedures and processes that indicate it, and that's actually how to do it. And this will assist in implementing coding compliance stages of detection, correction, prevention, verification, and comparison. So what some offices actually do is they have a process where they just start auditing medical records. So they may do a pre-audit. So this is before the claims get sent to the insurance company, or it may be a post-audit. So this is after the claim has actually been paid, just to verify that the documentation is matching what is billed and then looking at the reimbursement. So an effective coding compliance program will monitor your coding processes for completeness, reliability, validity, and timeliness. So they'll look at all of these factors to determine are they being followed in your compliance program. So some offices and practices will use what's called computer assisted coding. So in this process, what is happening is the computer is assisting either the doctor or the coder with the code that, based off of what it thinks it should be, it will assign a code. But you still need to verify that this is correct because it may make a mistake. So make sure that even if it is suggesting a code to you, that you are verifying it. Don't just assign the code that it gives, because it doesn't have all of the information that you may have. So a quick knowledge check. How will you avoid abusive and fraudulent medical coding practices? So define fraud and abuse as it relates to medical coding, and then list and define the terms associated with medical coding and fraud. So as we think about some of these questions, these are some of the things that we should think about. So think about incorporating the use of the above references and resources coders use and avoiding abusive and fraudulent, dishonest and illegal coding practices. We also want to make sure that we don't abuse. So an abuse involves mistakenly submitting incorrect codes, and fraud that involves intentional submitting of incorrect claims to increase reimbursement. So we always want to, stay away from that. And then again, we always want to stay away from anything regarding unbundling, upcoding, overcoding, jamming, downcoding. So anything related to that, we want to definitely stay away from, because we want to make sure that our claims go out clean we're paid correctly, and if we're audited, we'll be able to pass that audit because we build exactly according to the documentation. Very, very, very important. So when in doubt, ask questions. So some of the other classification systems, alternative billing codes. You also have clinical care classification system. You have your current dental terminology, which a lot of dentist offices will use those. You'll have your DSM, which your mental health organizations would use a lot of the DSM. You have your HIPS, which is this is your health insurance prospective payment system. You'll have your ICF, which is your International Classification of Functioning Disability and Health. Also, you have your LOINC, which is your Logical Observation Identifiers, Names, and Codes. You'll also have your NDC codes. So these are your National Drug Codes. You'll have your RX norm. You'll also have the SNOMED-CT, and then you'll have the UMLS. Now, you may not use all of these. You may use some of these. You may use one or two of these. So it just depends on where you're working and what type of coding you're actually doing. So, for example, if you're doing mental health, you're going to use the DSM. You're not going to use dental because you're not working in dental. So you're not going to use all of these. So these are just things that you just need to be aware of just in case if you hear about them. But depends on where you work will determine which one of these classification systems you'll be using. Medical necessity. You'll hear a lot about medical necessity. So what medical necessity actually does is it proves the reason why that patient actually came in for those services. So it required the provider to document services or supplies that are proper and needed for the diagnosis or treatment of the condition provided. So you'll hear this a lot. If it wasn't documented, it wasn't done. So for a medical necessity, for example, if a patient comes in and they say that they have knee pain and the doctor does an EKG, well, is the EKG medically necessary if the patient is coming in for knee pain? The knee pain has nothing to do with an EKG. So that would not be a medically necessary service. Now, if the patient said they has chest pain or um, something else related around the chest, yes, then we will use the EKG. But if they're coming in for knee pain, that has nothing to do with it. And so that's what they're talking about when they talk about medical necessity. So make sure that it's documented. If it's not documented, we can't code it. Remember that. So if it wasn't documented, it wasn't done. Even if we know that it was done, even if we've seen it with our own two eyes, if it's not documented, we have to not code it. We have to follow whatever is documented because that's what auditors are going to follow. They're not going to be able to stop and ask you, and do you remember this patient came in? Oh, yeah, they got that particular service, but it has to be documented. So make sure that you're only coding things that are documented. So documentation as the basis of coding. That is the actual medical record. It'll be a detailed listing of that patient encounter, and it documents why that patient actually came in for that visit. Continuity of care is documenting the patient services so that others who treat that patient will know what services they received and then why. So we want to always have that continuity of care. And then the documentation, it can be dictated, transcribed, handwritten. It could be computer generated notes and reports that are recorded in the patient's medical record, but it has to be signed off by a healthcare professional. So you won't actually see it until it's actually signed off, um, if it's an EHR. So that will help to keep things streamlined and make sure that the documentation is completed in a timely manner, and then that you're actually coding what you're only seeing. So very, very important. So the patient record can come in different formats. It could be paper. So that's what we consider a manual record. You won't see too much of that now. Most of the records are going to be electronic. They're going to be the EHR or they're going to be the EMR. So either one of those two. They could be a hybrid, which is a combination of paper and the computer, but most of it is going to be computer generated. So it's going to be either the EHR or the EMR. But there may be times where a record may come in and it comes in as paper. Now, what most offices will do is then scan that paper into the patient's medical record so that everything is now electronic. All right, so here's another knowledge check. So how do you think documentation serves as the basis for coding, diagnoses, procedures, and other services? So a patient record is a business record for a patient encounter that documents the healthcare services provided to that patient. It stores the patient demographic and data, documentation that supports that diagnosis, and it justifies the reason for treatment. The documentation serves as the patient record on the basis for coding your diagnosis, your CPT for your procedures, and other services, because it will support the codes that are reported on a claim to the third party reimbursement. So again, that documentation is very, very important. We have to have it in the medical record so that we are supporting the things that we're actually billing out. So with the data collection, it is performed for the purpose of administrative planning, submitting statistics to like your state and your federal agencies, and then also reporting claims to your third party payer. So the data collection is used for multiple things, as you can see. So reporting data from the hospital is normally going to be an automated case abstracting software. Now it could be that, or it could be the actual coder who's abstracting that data. They're going to submit those claims on a CMS 1500 or UB04, and then they'll generate reports. For the physician side, they're going to use the CMS 1500 claim form. Normally, they're going to use some type of medical managed software, and then they'll also be generating those reports. So this is just a screenshot of the data entry screen where we're adding that information into the computer system. And then this is just a sample of an agent report of everything that's going to be included in that patient's record for submitting to the insurance company. So it'll have, of course, the patient's name, of course, the date of service. It's going to have their insurance information, the charge amount, and then where it falls, if it's in the 30 to 31 to 60, 61 to 90, 91 to 120, or if it's current. So it's going to let us know that. So the agent report is going to give us a lot of information about what's going on with each patient's, accounting. So are the claims being paid? Are they denied? Do we need to resubmit? So things like that, that's what you're going to find on your actual agent report. So that's just a summary of what you're going to encounter while you're using reimbursement. So that's going to conclude for our week 1 lecture. If you have any questions, please feel free to reach out to me and I'll be more than happy to answer any questions. So thank you and have a great week.